I welcome everybody for our deliberation and discussion on adolescent polycystic ovarian syndrome. Beware and be aware. It is about me. I'm presently associated as a co-chair SAFOG NCD committee and has been organized many conferences and had posts at the national and international level at various platforms. And I thank everybody for always being together for all academic activities, skill and knowledge enhancing workshops, publications, pan-India and across India. I owe a big thanks to everybody. Now coming to topic polycystic ovarian syndrome. Actually, all clinicians are sometimes say that it is too much. They all have to deal, and the different specialties deal polycystic ovarian syndrome in women of different age of life. Because PCOS is a common, complex and heterogeneous familial disorder, it has got a genetic predisposition, so it is a familial disorder. It affects 5 to 15% of females of reproductive age, and in India, when there is an absolute population is quite high. It is seen across race, ethnicity, country of origin, and other socio-demographic backgrounds. So it is not now a problem of cities or the developed or the high socio-economic status. It is affecting everybody. And especially my talk will be on the adolescent PCOS because it has been now recognized as an important reproductive health issue because it has a significant effect and reduction in health-related quality of life. It is the most frequent endocrinopathy, and what should we suspect when we encounter any girl with the oligoanovulation, that is delayed cycles, hyperandrogenism and polycystic ovaries? It is characteristic of PCOS. It usually presents at puberty, and the precise prevalence of PCOS in adolescent we don't know because of the upcoming discussion because of the diagnostic fallacies, but still the minimum incidence is around 1.1% when we use the NIH criteria. So a brief overview about the etiopathogenesis. Actually, we don't know that what causes PCOS, and what we know till now, which I will like to share. In adolescent with PCOS, there is a imbalance in steroidogenesis, which cause exaggerated LH response, which drive androgen production and inadequate FSH, and then it is inadequate conversion of androgen to estradiol. So the follicular arrest is there and there is oligoanovulation. Adolescent with PCOS often demonstrate insulin resistant and hyperandrogenous, and it is more common in overweight and obese girls. And the change in insulin and androgen metabolism appear to be interrelated because when there is an increase in androgen, it causes reduced insulin sensitivity, and when there is a high insulin level, it potentiates androgen secreted in the fat tissue. So what cause what? We are really sometimes fail to know different flow chart, different metabolic pathways in different women and the girls, but the both accentuate each other. That is the insulin resistance cause hyperandrogenemia and hyperandrogenemia cause insulin resistance. So here we are that how the insulin compensatory, when there is insulin resistance, high insulin level cause increased DHP and the androgen level. At the same time, it causes SHBG hepatic production is reduced, which cause increase in circulating free testosterone, and that finally cause increased GnRH pulse frequency and LH excess. So this is the thing what we know till now, and how it is developed from fetal life to adolescence. Yes, PCOS presents at puberty, but actually the risk factor are from the IUGR, babies, which cause finally turning into the childhood, or the pre-pubertal obesity. The girls come with the premature puberty and the family history that the mother with the PCOS. So it is an ongoing procedure, and the things right from intrauterine life to the families, to the children and adolescent, and finally the reproductive and elderly age women. So what are the classical clinical presentation as a clinician we are concerned for that? So what is the classical teaching? That is the patient GERD with the acne, hair growth with the obesity and having the delayed cycle followed by prolonged bleeding. Whenever you find a GERD with a 2 or 3 month amenorrhea followed by 8 to 10 days bleeding, the first thing comes to in your mind is the polycystic ovarian syndrome. But there is non-classical and mixed presentation, and especially it is important in adolescent age group. So this is very, very important that why we are talking today of adolescent PCOS, because it is an important reproductive health issue for adolescents. Secondly, if we don't diagnose or the delay diagnose, when we lose the opportunity for lifestyle modification and the prolonged, like long-term outcome in the infertility and in the metabolic disorder. But if we over-diagnose, the girl is not having PCOS, but you diagnose as PCOS, then there are a lot of psychological issue, anxiety and apprehension. And that's why we should be very, very clear that how to diagnose PCOS in the adolescents. Now, why the diagnosis is difficult in adolescent? Because adolescent is the period of the physiological and the psychological maturation. So there are a lot of things are happening in the adolescent age. So the all symptom like the oligoanovulation can be physiological, acne can be physiological. So many symptoms of PCOS actually overlap with the normal physiological changes in the adolescent period. The one thing is important that makes the diagnosis difficult. Secondly, we do ultrasound abdominally, and again, the characteristic of normal pubertal ovary overlap with the symptom of PCOS. So the PCOS is seen by different specialties. It is genetic disorder. The women also come to dermatologists, endocrinologists, gynae, and the androgens, for the androgen society, it is hyperandrogenism mainly. So we have to be very clear that adolescence is also a period of the rapid changes, and acne are physiological. They can be common. Weight gain due to many reasons. Thyroid and prolactin disorders are very common. A lot of stress, like the career issues, the educational issues are there. So a lot of psychological stress and the normal physiological immature hypothalamic pituitary axis, which cause oligoanovulation physiologically, and what we say the imaging can be suboptimal. So a lot of research is going on that how we should diagnose PCOS in adolescents, and I will like to make few very gray area clear to benefit of everybody, because that is the area where we need a lot of research and lot of clinical carefulness when we term any GERD with the PCOS. Why we want to diagnose PCOS in an adolescent, that early age group? Because it is associated with risk of chronic anovulation, infertility, cardiometabolic disorder, obesity, type 2 diabetes, mellitus, hypertension, risk factor for cardiovascular disease, and the endometrial hyperplasia and carcinoma. So we all, India is and the South Asia, this region is troubled with the tsunami of NCD thanks to a rapid change in last 15 years in our eating and the ways of living. And when we diagnose PCOS at right age, that is at adolescent, and teach her for all lifestyle intervention and all the things about it, we can really prevent that tsunami of NCD in our country. That independent India actually looks for healthy India, and as an obstetrician and gynecologist, we have a long role to play. So we want to diagnose correctly for the adolescent PCOS. We don't want to overdiagnose, we don't want to wrong diagnose, and we don't want to miss the diagnosis. So how to diagnose in adolescent? Because these are the advantage what we have seen, that we can do the right positive lifestyle intervention and positive treatment to prevent long-term complication. But how to diagnose adolescent PCOS in adolescents? So we have the typical Rotterdam criteria, Androgen Access Society criteria, and the NIH criteria. So Rotterdam includes polycystic ovaries, morphology on ultrasound beside oligoanovulation and hyperandrogenism as by NIH and Androgen Society. But there is to be taken with a pinch of caution, because we say that all three criteria for Rotterdam should be fulfilled when we term a adolescent girl with the PCOS. So this is very, very important. Sultan and Paris, they are very, like, this is very important and very significant, that they say it should be oligoamenorrhea for more than 2 years, clinical or biochemical hyperandrogenism, sign of insulin resistant, and polycystic ovarian morphology. And they say that at least 4 out of 5 criteria should be present when we label a girl with the adolescent PCOS. So mind it, don't give the diagnosis for a one ultrasound that is abdominal, that is multifollicular ovary and the delayed cycle, and you term the girl with PCOS. So it is not so. Be careful that the girl fulfill 4 out of 5 criteria when you term the girl as a adolescent PCOS. Why this is important? Because again, I emphasize that there is a very thin line between normal and the abnormal in adolescent. The more many girls have the immature or the irregular cycles in 2 to 3 years after menarche, and there has been a wide variation, and we have to look and follow these girls that how their menstrual pattern is going on in next 2 to 3 years. So one side, everybody says, doctor also think, family also think, yes, it is delayed, it is normal, but it can be the manifestation of PCOS. So it is important that when there is a menstrual cycle interval less than 20 days or more than 90 days, it is abnormal even if first post-menarchal year and require further follow-up and investigation. And the risk of anovulation is greater in adolescent with hyperandrogenism, especially the clinical signs. Then they should be, if it is delayed cycle with the clinical sign of hyperandrogenism, the girl should be followed for the PCOS confirmation and evaluated for the same. So if the girl is having delayed cycle more than 90 days, if she has not attained menarche by age of 15 years, or she has not attained menarche 2 to 3 years after thelarche, regardless of chronological age, warrants further evaluation and consideration such as PCOS. So this is very important message I want to give. Though there is a physiological immature hypothalamic pituitary axis and there can be irregular cycle in first 2 years, but if it is a very, very irregular right from beginning and the primary amenorrhea by age of 15 years, these girls to be followed, and at least the lifestyle intervention should be advised right at that period and that age. Hyperinsulinemia, which is the hallmark of PCOS, it's also common in healthy adolescent, and the insulin sensitivity decrease about 50% with increase in insulin secretion in adolescent. So you must be well aware of it, and when there is insulin, there is a inhibiting the production of SHBG and the increased free androgen level. So it is important. What message I want to give, that the insulin resistance can be physiological in adolescent, but if the girl is having obesity, she is having the manifestation of insulin resistance like stripe, increased central abdominal thickness, we should consider the possibility of PCOS and its related comorbidities, including metabolic syndrome. So this is very, very important. Now coming to hyperandrogenism, which is one of the important criteria for diagnosis of PCOS. And again, we have to be very careful what is a normal variation in adolescent and what is the pathological. Professional bodies is still, there is no agreement. But one message I want to give to all, that the comedonal acne is common in adolescent females, but the moderate to severe inflammatory acne is scarce during puberty. So if the girl is having moderate to severe inflammatory acne, first evaluate for the hyperandrogenism and then go for the topical or the systemic medical treatment, because if the treatment is started, it may mask hyperandrogenism and you may, like, they have all the bleaching and everything, and you may miss the important signs and the lab investigation, which is pointing towards the diagnosis of PCOS. So this is one important clinical message I want to give. Now, how to demonstrate androgen axis? So it is easier said than done. There are few total and free testosterone DHEAs, but actually there is a lot of issue about its the diurnal variation, what is normal for a adolescent girl. But a total testosterone more than 90 microgram per deciliter is considered androgen axis. It is very important that the clinical, I wish to emphasize that the clinical sign of hyperandrogenism, that is hirsutism, excessive acne, it should be considered, taken as a sign of hyperandrogenism. And when it is not there clinical, then you can like diagnose it, or you can do order total and free testosterone, so you see what is going on. So it is very, very important when there is a persistent elevation of serum total and free testosterone level, that is 2 SD above mean of adult form, then it is very important that it should be determined by a good reference laboratory. So this is very important. Then it is also a valid criteria for the biochemical hyperandrogenism. So if there is a clinical sign of hyperandrogenism, you may omit the testosterone estimation, but a patient with a oligoanovulation and sometime you are in doubt, then you can order the total and free testosterone, that to see what is the level, and still always give this test to the very, very good laboratory, because it is also important that we have the good reference standard. So what is the takeaway? That the insulin resistance and hyperinsulinemia should not be utilized as diagnostic criteria, because nowadays we see a lot of fasting insulin level, glucose level, but it is not a diagnostic criteria and usually does not need for the diagnosis of PCOS, and it is not recommended because it may give you the wrong ideas also. So third important thing, that the PCOS is always a diagnosis of exclusion. Always diagnose, exclude hypothyroid or the hyperthyroid dysfunction, prolactin level estimation, exclude non-classical adrenal hyperplasia, because it is the most important disorder in the differential diagnosis of PCOS. And don't order AMH for adolescent girl, because we don't know what are the normal AMH level in the adolescent. So it is not to be ordered for the adolescent PCOS. Now coming to the third gray area, that is PCOS morphology. So I want to say two things, that we do usually abdominal ultrasound in the adolescent girl, and the imaging is suboptimal. So with the today's good machine, the volume of ovary should be more than 12 and the follicles should be more than 20. So this is very important, and don't do ultrasound for the diagnosis of PCOS until 8 years after menarche, because we have normally multifollicular ovaries. So this is very, very important, that the polycystic ovarian morphology not to be done USG till 8 years after menarche, and if it is you do after 8 years, then it is a 12 cc volume and more than 20 follicles in one ovary. So this is very, very important. Again, I emphasize that the correct diagnosis of PCOS is very, very important. So TSH, prolactin level for all, AMH level to not to be recommended, ultrasound postpone it till 8 years post menarche, and always look for the hyperandrogenism clinical or sometimes the biochemical hyperandrogenism. So there are all new papers which I am sharing with you, and you see how important is the research work and the evidence and the experience sharing in the area of adolescent PCOS. It is always to be diagnosed, and it is always a diagnosis of the exclusion. Now, coming with this basic knowledge, what is the clinical approach to adolescent which have the suspicious PCOS? So I say deliberately, I emphasize that always say you don't term the adolescent PCOS at the first sight, at the first visit. You select those patients who can have the PCOS, and you have to determine in your OPD who are the girls which should be screened further, how you demonstrate androgen excess clinically or biochemically, how you have excluded the disorder which is mimicking PCOS, and what is the cause of excessive level of androgen, because it is not only ovary, it is the extra ovarian source also which is producing androgen. So again, you know your patient, right from Hippocrates to everybody, we have to know our patient. So take a good family history. because PCOS tend to cluster in families. Always ask if your mother, father have got hypertension, diabetes, look at the parents, what is their weight and what is their constitution. What is personal history? In adolescent, it is very, very important. The girls go for the experience smoking alcohol when they are in hostel, food, they are very much anxious about their competitive exam, sometime about relationship, and that is very, very important. Two things. First of all, these things can cause the endocrine disorder. Secondly, the PCOS girls also have a lot of psychological issue, and right from the very beginning, we should be very careful of the sympathetic about them. What is physical appearance? What is BMI, height, weight, and the menstrual calendar? Very, very important. Age at menarche, what happened for the first 2 or 3 years, from how many years she is having delayed cycles, and acne and the hairs. Look at the patient, ask them to remove their mask, or if there is any hijab or something, and look for the patient whether they are having this hirsutism, the hairs on the temporal region, and what has been the weight pattern. Thus, there has been the weight gain in the last 2 years or last 1 or 2 years. Look for the secondary sexual characters. This is very important because the PCOS girls have the history of precocious puberty sometimes, and see the acanthosis nigricans, dark velvety skin in axillary and intragenous area. Why I am emphasizing that in today's scenario, there is something of pattern that ordering test and diagnosis and at the very quickly, and we don't want to look at the patient, and this remains the hallmark of the diagnosis for the adolescent PCOS also. It is what I have emphasized, that it is always a diagnosis of exclusion, and when we are having the high androgen level, always do ultrasound for the images of adrenal gland also. So this is very important. Guard with the weight gain, with the edema, with the hypertension, with histria. Always look for the ultrasound, not only for the pelvis, but also for the adrenal gland, and the anabolic steroid abuse, which is sometimes common in the sports. Always say delayed cycle. Sometimes you have to confirm UPT, thyroid prolactin, and rule out non-classical adrenal hyperplasia caused by 21 hydroxylase deficiency and the Cushing syndrome. So whenever there is a premature puberty and the prepubertal acne, it raises suspicion of non-classical congenital adrenal hyperplasia, which is a most important differential diagnosis of the polycystic ovarian syndrome. So my takeaway is that order the lab test, which is actually guide you some way, and which can really make you think that it is not a thyroid, it is not a prolactin, it is not a adrenal thing, and it is a PCOS. So it is very, very important. And again, AMH is not recommended. The testosterone have their issues with the good reference lab, with the diurnal variation. But if it is persistently 2 SD above the normal level, then we consider it as a biochemical evidence of hyperandrogenemia. Do all girls need the lipid profile and the glucose tolerance test? No. Yes, fasting glucose tolerance test or the glucose challenge 2-hour PP test is recommended for everybody. But the lipid panel is considered in the overweight adolescent PCOS, or if she is normal weight, but she has the family history of dyslipidemia. So PCOS and metabolic syndrome is a nexus. They are interrelated. So when we consider a girl with the possibility of metabolic syndrome, fasting blood glucose level more than 100, high density lipoprotein less than 40, triglyceride more than 110 milligram per deciliter, waist circumference 90 percentile for age, and the blood pressure 90 percentile for age. And so many times the young girls don't miss the BP measurement for these young girls. It is a mandatory that in OPD, every patient, and whether it is a 13-year or 14-year or 16-year girl, never omit blood pressure measurement, because it makes you different and it makes you careful about the other pathologies, other differential diagnosis of PCOS. How to manage in our clinical practice with this roadmap, with this basic knowledge, and then with basic workup, what we have to offer to these girls and what we have to counsel to the families of these girls. So lifestyle modification is the first line, second line, and third line. It goes all over the life, and we have to be very, very careful that we don't counsel them as a punishment. It should be positive. It should give happiness to them. And here is the gap in the medical practice, which we seem to forget, that it should be very friendly, pleasurable, and the relaxing lifestyle modification. It should not be taken by girl and family as a some sort of punishment. So it creates like a vicious cycle of anxiety and more not following the positive lifestyle intervention. What are the pharmacological agent, that is COC, metformin, and we will just take how every drug works. This is very important concept I wish to present to everybody, that the pre-pubertal metabolic dysfunction may be one of the first phenotypic traits observed in adolescent girl which can develop PCOS. So till now we say that the PCOS appear present as adolescent. Now with the pediatric and the endocrinology, we are coming to that point that if at the age of 7, 8, 9 years, if there is a weight gain, then this girl can have PCOS, and we should start the lifestyle intervention, like look at what type of diet she is having, baby is playing in field or not, she is like moving around or not, and we have to catch them even before puberty. So this is one of the important landmark message I want to give, that catch them even before puberty, because at that time the lifestyle intervention and counseling of parents will go a long way in prevention of full-fledged PCOS, because PCOS is a genetics plus epigenetics. So if the epigenetics is improved with the good food habit, good quality habit, and the importance for the playing of the girls, then it can prevent the PCOS manifestation, even if the girl is genetically susceptible to PCOS. So it is important, it is a diet and it is exercise which actually work. And we know that yes, that weight loss has been associated with the symptomatic, clinical, and metabolic improvement in PCOS. But a second point that is emerging concept is it is not the quantity of diet, but it is the quality of diet which is important in the lifestyle modification. So I bring your attention to a very, very important dogma theory as an emerging concept for the etiopathogenesis of PCOS. Till now, we say insulin resistance, insulin resistance, insulin resistance. But why there is insulin resistance? So it is a novel thought. The microbiological hypothesis is a novel paradigm that suggests that if there is a poor diet, it results into disturbed bowel bacterial flora, which cause mucosal damage and increased gut permeability. That allows lipopolysaccharide from gram-negative colonic bacteria to systemic circulation, and it results into activation of immune system. And this activation of immune system release cytokine, which interfere with intracellular insulin receptor function and which drives up serum insulin level, and which in turn cause hyperandrogenemia and oligoanovulation. So what is our Indian philosophy? What we eat, we become. Like focus on the diet. So this is a very, very important understanding of PCOS, that it is not quantity of the diet, but it is a quality of diet. Because when there is a disturbance of that microbiome, it causes activation of immune system and cytokines. So that's why the lifestyle modification really works for the PCOS. And what we can do in the simplest way, that 30 minutes to moderate to like good exercise, walk to your college, don't go like for small things, like go on foot, don't go for by the car or the bike, take high fiber complex carbohydrate fat. There should be low in fat, low glycemic index, low sugar, and the high fiber to be avoided, and the high fiber, high food in the essential fatty acid and antioxidant food. So it is a simple, it seems complicated, but it is simple. It is the whole grain, it is the pulses, it is fruits and vegetables. Whosoever food is colored, whichever food is colored is having good antioxidant, they have a good fiber and the good roughage, and they are the complex carbohydrate. So it is very, very simple. It is the diet which we do simply use, and India is fortunate to have a wide variety of cheap fruits and vegetables, and we have to emphasize to these adolescent girls that this is the only way to keep you healthy, and no packaged food, no junk food, no samosa, no Maggie, no pizza. So this is, if it is only once in a month or something. So this is very important, because we have to make this lifestyle modification approach to good food is a very positive, healthy, and the happy way of life. It should not be done as a punishment. It is important, and why we are facing this challenge, because all the celebrities are selling cold drink and the junk food and the big pieces from the McDonald's. So a lot of industries is against the healthy food habit, and that makes our work very difficult. But it is the time that as an obstetrician and gynecologist, we owe this duty to our people, so that we have healthy people in our country. Now, after lifestyle modification, the combined oral contraceptive are the second line of treatment. And the combined oral contraceptive are the thing which correct the endocrine abnormalities in the girls with PCOS, because it correct menstrual irregularity, it correct dermatological manifestation of PCOS, it block activity of plasma androgen, that is free testosterone, and they also increase sex hormone binding globulin, so reduce the androgen level. So minded COC is not a symptomatic treatment. COC is a treatment which correct endocrine pathologies of the polycystic ovarian syndrome. What we have to offer, choose the drug which is affordable, as well as see that what girl is having the symptom. So if girl is obese, overweight, then the ethinyl estradiol and the drospirenone can be better choice. If she is troubled with the acne and the hirsutism or the more hair growth, then the cyprotenone combination can be better, because they have more anti-androgenic effect. Keep an eye on usual contraindication of COC, and the COC which contain less androgenic progestin may have less deleterious effect on insulin resistance and lipid profile. So this is important. How long to be given COC? So it is important that after 3 months of treatment, you review and you reevaluate that the lifestyle function intervention are working or not, and she is assuming the normal menstrual cycle or not, and what is happening to hair growth and the acne, because still in the young girl, the long-term COC, what is they have effect on the fertility and other things, we are not very sure. So these are few questions, and the parents also say always that the girl, her height is less and you are prescribing this thing, and their question are genuine. We actually don't know what will be the long-term consequence and infertility on their height. They can have post-pill menorrhea. They are not going to have menstruation without pills, and they issue with the headache. Sometimes the girl really, they are on computer, they are on the studies and something. So it is very important that we review after 3 years, after 3 months of the COC used in the adolescent PCOS. Withdrawal bleeding for progestin, we can give 10 milligram DD for 5 days or 10 milligram DD for 10 days. But I want to differentiate that it is only for the regular menstrual cyclicity, but it does not correct the endocrinopathy and the endocrine change involving in the PCOS. And it has that, like some people have really effect and side effect like mood changes and the bloating and the headache. So this is important that we differentiate between. Metformin is the third drug which is supposed to be insulin sensitizer. We have used a long way, like in PCOS, especially in infertility. But in adolescent, we have to be very careful. And if the lifestyle intervention and the first line treatment is not working, sometimes we have to add, especially in the overweight girl. But there are a lot of like loss of appetite and the gastric issue. So metformin is to be taken with a little caution, and when you think that the first line therapies is not working. Inositol has come in a big way because they are a nutritional product. Metformin is the insulin sensitizer, and the one thing I wish to say that with the metformin, it resumes menstrual cyclicity. So the girl is sexually active, we have to inform of this risk. and the counseling for the contraception option. So inositol has come in a big way, myoinositol, dichloroinositol in ratio of 40:1, and insulin, it correct insulin resistance by the multiple channel, by the multiple P13K kinase and the second messenger at the insulin level. The important role of inositol in the adolescent PCOS is that they are nutritional product. They don't have side effect. We can give them for a long period without like worrying for the other thing, but they have the moderate cost. They are not very cheap. They are not very costly. So there are a lot of research going on the food supplement that can be effective in adolescent PCOS, because it is finally it is what dogma theory says, what inflammatory stress theory says, that it is related to some way to our lifestyle, and the world is looking for the food supplement, that is DHA, inositol, berberine, curcumin, prebiotic, probiotic, and the emerging food supplement. So can the food itself, food product or the nutritional supplement can help in the adolescent PCOS? This is, we have to like have a lot of experience, and now we have a lot of experience in 3 to 4 years, and they are found to be not very much effective, than the pretty effective also. When there is a hirsutis which is not responding to COC with the cyprotenol, then we have to sometimes give spironolactone and the flutamide. That is a second line drug. Usually obstetrician and gynecologist does not write, because it is to the physician and by the endocrinologist. Flutamide has the issue because it is a risk of hepatotoxicity, and spironolactone is the most commonly used anti-androgen therapy. So still there is a paucity of literature on use of these medication in adolescent population. So what is the role of combined therapy? Lifestyle, then the COC. Sometimes we add metformin. Inositol has come in a big way, and anti-androgen only to be considered when we want to treat the androgen-related alopecia or improve hirsutis. Supportive treatment. Now, mental health, I will again emphasize that these girls, when you say very quickly in the blink of eye, oh, you are PCOS, and she reads on the net, or sometimes she discusses with her friends, and they become very, very anxious about their future reproductive potential, their appearance for which they are worrying about the hairs, acne, because it is the period of the relationships and the friendships, and they are like, so there is a lot of mental issue. My message is that don't make them more anxious from the medical point of view. You have to understand, you have to make them understand that it is a thing. Yes, it is an endocrine abnormality, but 90% of things is in your hand. If you will follow the good food, the good exercise pattern, and stress-free life, that it will help. And sometimes we have to give the thing. So don't tell everything wrong about all the cancer and the something, but make this opportunity to make the positive intervention. Because we don't know actually what is causing PCOS in last 20 years, 15 years. So we have been trying everything for PCOS, acupressure, acupuncture, massage therapy, but still we don't have any thing which is effective really. A lot of research gaps are there in adolescent PCOS, right from the diagnosis, absence of longitudinal studies during adolescence, and what is the normal value for the different biochemical markers. So there is a lot of research gap, and I invite everybody to work on it, whosoever in teaching institution who are research minded, that you do research, because in India we treat a large group of, every clinician treat so many patients, and it is we who can really give our input and experience for this PCOS, which is an important public health problem. So finally, to end, the standard diagnostic criteria, you should be very, very careful in diagnosis of PCOS. Always don't give diagnosis at one hand, but follow the girl for the 2 to 3 years. And when at the right time, you will say label it PCOS, but you start lifestyle intervention right from the very beginning. So this is very important, and always address the physical and emotional health. Give the good drug treatment has got a limited role, especially in adolescence, and always encourage the positive lifestyle intervention. And I also seek everybody's support for my Foxy presidential candidature, for which election will be held next year. I have worked the federation and many professional body at national and international forums, and we look forward to working together for a long time. Thank you very much.